We are going to start the webinar, and it is my pleasure to introduce Professor Manuela França. She is head of Radiology Department at Central University Hospital of Porto, and she has a large experience, clinical and research experience on working on MR imaging biomarkers in different liver disorders. So today she's going to talk to us about the MR quantification of hepatic fat and iron and how does it work in practice. So during the conference you can write down your questions in Q&R section or at the end of the conference, and so at the end we will have time for discussion and to answer your questions. Thank you everybody for being here, and please, Professor Manuela França, you can start.
Okay, so thank you and good afternoon to you all. Thank you to the USOMI board for the invitation, and thank you for this kind introduction. So this is my topic, and these are the learning objectives that were proposed. And I will start this presentation with a clinical question, that is, why do we need liver fat and iron quantification? And let's start with liver steatosis. Well, steatosis or fat accumulation is the histological hallmark of non-alcoholic fatty liver disease, which is now the most frequent liver disease in the Western countries. NAFLD comprehends a spectrum of disease ranging from simple steatosis to non-alcoholic steatohepatitis, which is defined by steatosis plus inflammation. And it may progress to cirrhosis, liver failure, and those patients may develop HCC. In fact, NAFLD is now the second cause of liver transplant waiting list in the United States. And moreover, because NAFLD is considered the hepatic manifestation of the metabolic syndrome, it is also associated with an increased risk of diabetes, cardiovascular disease, and even non-hepatic cancer. However, steatosis itself is not a diagnosis. It is a common feature that we can see in many other diffuse liver diseases such as viral hepatitis, alcoholic hepatitis, genetic liver diseases, etc. And in these cases, steatosis adversely affects the disease progression, is also associated with HCC, and it can worsen the prognosis of patients undergoing liver surgery or liver transplantation. And although currently there is no cutoff or limit where liver fat content is considered too much or harmful, understanding this disease spectrum, we see that there is a need to know the exact amount of fat in the liver for risk stratification or response assessment. And the European guidelines suggest lifestyle changes to all patients with NAFLD or NASH, including a healthy diet or exercise. But in patients with NASH and significant fibrosis, the use of pharmacotherapy could be advantageous. So there is a need for more precise quantitative methods to monitor this large number of patients with NAFLD or NASH, and in the scenario of research studies or clinical trials with these new drugs that are being developed for NASH. And what about iron? Well, iron overload can be primary, like in hereditary hemochromatosis, when there is a genetic defect that increases the absorption of iron, or it can be secondary to an oversupply of iron, like in chronic blood transfusions or hemolytic anemias. And those patients with iron overload need iron-reducing therapies, lifelong phlebotomies in cases of hereditary hemochromatosis, or chelates that bind to excess of iron in cases of secondary iron overload. And this is to prevent, of course, the iron toxicity. And what is the relevance of measuring liver iron in these disorders? Well, Liver iron concentration is closely correlated with the total body iron stores, so it has been used as a surrogate for the total body iron burden that is important to diagnose iron overload, to select the patients who need treatment, and to monitor these iron-reducing therapies. But besides primary hemochromatosis and transfusional iron overload, mild to moderate iron overload can be found in chronic diffuse liver diseases such as NAFLD, viral hepatitis, alcoholic hepatitis, and so on. And in this scenario, hepatic iron deposits appear to have a synergistic role in the progression of liver fibrosis and cirrhosis and increase the risk for HCC. However, we must understand that in this scenario, the actual hepatic iron burden is far below the 35 micromole per gram threshold that is used as a definition of iron overload in the scenario of hereditary hemochromatosis or secondary hemochromatosis. And even the presence of mild iron excess in the liver may represent a risk for toxicity. Furthermore, in the scenario of chronic diffuse liver diseases, it is quite frequent to have both fat and iron coexisting in the liver parenchyma, both acting as cofactors in disease progression. And finally, we can also have hepatic iron overload in the scenario of dysmetabolic iron overload. That is defined as hepatic iron overload in association with one or more metabolic abnormality related with insulin resistance, such as obesity, dyslipidemia, or abnormal glucose metabolism. So these patients have hyperferritinemia, and usually the iron excess is mild, but in some cases it can be as high as in hereditary hemochromatosis. And because this is associated with metabolic syndrome, it's not surprising that liver steatosis and steatohepatitis are also commonly recognized in the liver biopsies of these patients. Okay, so how do we measure liver fat and iron? Well, the reference standard usually is liver biopsy. In liver histological examination, the pathologist rate hepatic steatosis, iron overload, inflammation, and stage fibrosis using visual scores. However, this gold standard has several limitations. First of all, it is invasive, has a large sampling bias, and we know that diffuse liver diseases can be quite heterogeneous in the distribution, and don't forget that liver biopsy analyzes only a small portion of the liver parenchyma. Also, it is operator dependent with high intra and inter-examination variability, so it's not feasible for following up the large number of patients with diffuse liver diseases. And that's why there is a need to find non-invasive biomarkers able to detect, quantify, and monitor steatosis and iron deposits in the whole liver, obviating the need for liver biopsy. And we know that imaging techniques can recognize fat, for example, non-invasively. However, in the case of fat, either ultrasound or CT are generally accurate only in the detection of moderate and severe steatosis, and they are not useful for iron quantification. MR, on the other hand, is the imaging modality that provides more information about different tissue components. And we know that for several years, we are using the T1 chemical shift sequences to detect hepatic fat. And those sequences take advantage of the different resonance frequencies and chemical shifts of water and fat protons. So images are acquired when water and fat protons are aligned or in phase, or in opposed phase. And steatosis is recognized as the signal loss on the opposed phase images relative to the in-phase images. So this scheme exemplifies the signal intensities with increasing TEs in a normal liver and in a liver with fat, in a steatotic liver. However, if there is iron in the liver parenchyma, there will be a fast signal intensity decay because iron has a paramagnetic effect and accelerates the T2 star decay. So when fat and iron coexist, as occur as we saw in diffuse liver diseases, the T2 star decay can obscure the effect of fat in the liver signal intensity. So these sequences are not able to accurately measure liver steatosis. We can also recognize hepatic steatosis using T2 weighted images if we apply also fat suppression, and the hepatic fat will be recognized by a signal loss in the fat suppressed images when compared to the non-suppressed T2 weighted images. So these classical sequences allow us to recognize different patterns of hepatic steatosis, like in this case with homogeneous distribution with a small spared area, or with a heterogeneous distribution. Or we can have spared areas surrounding focal liver lesions, or even a pattern like this, a nodular or pseudonodular pattern. But these sequences are not able to quantify fat. So how can we quantify hepatic steatosis? Well, the imaging reference is MR spectroscopy. With MR spectroscopy, we can measure the density of the water protons and also the density of the multiple fat peaks that we can find in the liver spectrum. Then, applying this formula, we can calculate the proton density fat fraction, which is directly related to the molecular density of fat, so it is considered a fundamental property of tissues. And MR spectroscopy is considered now the imaging gold standard. It is accurate, reproducible, and sensitive to small variations in the liver fat deposits. However, it is expensive, it's time-consuming, and it needs dedicated analysis tools, being mainly performed in specialized hospital centers. So we cannot use this in our clinical practice. And so how can we do it? Well, to accomplish quantification of fat more easily, multi-echo chemical shift encoded sequences were developed in the last years. Those sequences take advantage of the different chemical shifts of water and fat protons, and they acquire multiple echoes, allowing to separate the water and the fat signals. And within the same sequence, because we acquire multiple echoes, we can also estimate the T2 star decay. This T2 star estimation will be used to correct the effect of T2 star decay in fat quantification, and we can also use it to quantify iron, because the T2 star decay is related with the iron content. We must use a low flip angle to minimize the T1 bias, and we should also incorporate the multiple fat peaks in our signal intensity model. And with these sequences, we can so quantify PDFF for fat quantification and R2 star for iron quantification. And this can be performed with sequences from the different vendors or using in-house advanced methods. This is the sequence that I'm using at my institution in a 3 Tesla equipment using 12 different TEs, and we can acquire images of the whole liver during one single breath-hold acquisition. So then we use a dedicated software, and we can measure PDFF and R2 star using our ROIs that must be placed avoiding vessels, lesions, or artifacts, or we can use parametric maps that have the advantage to show us the distribution of fat and iron throughout the liver parenchyma. So these sequences are well correlated with MR spectroscopy measurements and liver biopsy. In fact, in this meta-analysis published by the RSNA-KIBA PDFF Biomarker Committee, in which they compared MR PDFF with MR spectroscopy PDFF measurements, PDFF obtained with these multi-echo sequences demonstrated an excellent linearity with a negligible bias, with a high precision across different field strengths, vendors, and reconstruction algorithms. And we also compared PDFF measurements with a liver biopsy with an excellent correlation and with a high accuracy to diagnose the different grades of liver steatosis. Quite relevant, it is important to understand that in spite of being highly correlated, both techniques do not quantify exactly the same thing. I mean that PDFF and histological steatosis are strongly correlated, but they are not equal. With MR, we estimate the proportion of protons contained within fat molecules in a 3D liver voxel, whereas with a histological analysis, we evaluate the proportion of hepatocytes with macrovesicles of fat. So different metrics for the same thing. Okay. But we know that liver steatosis frequently coexists with iron, inflammation, and fibrosis, particularly in the scenario of diffuse liver diseases. And all these histological features can modify the signal intensity of MR. So it is important to interrogate the role of these possible confounders in steatosis quantification. So in a study with more than 100 patients, we reported that we can use these multi-echo sequences to simultaneously quantify steatosis and siderosis with a high accuracy in a wide spectrum of diffuse liver diseases and regardless the coexistence of liver inflammation or fibrosis. In fact, PDFF was unaffected by liver fibrosis or inflammation, and iron deposits did not affect PDFF quantification except in cases of severe iron overload, because the large iron content can lead to extremely low MR signal in gradient echo sequences. So in cases of severe iron overload, the fat water decomposition can be compromised due to the lack of signal, and PDFF quantification might be hampered in cases of iron overloaded livers. In our study, in livers with R2 star measurements higher than 500 seconds minus 1. So PDFF is now considered the best MR imaging biomarker for liver fat quantification, and it was considered to be even more precise than liver biopsy for therapy monitoring in patients with NASH, and it is also being used as a secondary endpoint in clinical trials for new drugs or interventions tailored for NASH. So now let's move on for iron. And iron, as I said before, accelerates the T2 relaxation and mainly the T2 star signal decay. So iron will be recognized by a low signal intensity of tissues on T2 weighted and T2 star weighted images. And there are two main methods for iron quantification. The signal intensity ratio methods compare the relative signal intensities between the liver and the reference tissue, usually the usually the skeletal muscle that does not accumulate fat. On the other hand, relaxometry methods are based on the calculation of relaxation time constants. But these methods require calibration. We must compare the MR measurements from signal intensity ratio methods or relaxometry methods with liver iron concentration measurements to generate empirical calibration curves, because with MR, we are not measuring iron directly. We are measuring the effect of iron on the neighborhood protons. And I will focus my presentation on relaxometry methods because those are the ones that I work on. And relaxometry methods require a series of images acquired with increasing TEs, and then the signal intensity is modeled in function of TE, and the signal decay constants are calculated. If we are using a spin echo sequence, we calculate the R2. If we are using a gradient echo sequence, we calculate the R2 star. And those constants are closely correlated with the liver iron concentration and liver biopsies. The most known R2 relaxometry method is currently available as a commercial service, which is FerryScan, that is approved by the FDA. And after calibration, this method requires 5 T2 weighted sequences that are acquired during free breathing, and then the images must be forwarded for centralized image data analysis. So this method is robust and reproducible. However, it requires long acquisition times, and because it is acquired on free breathing, it is prone to motion artifacts. And importantly, this method has a high cost. On the other hand, R2 star relaxometry methods are acquired with spoiled gradient echo multi-echo sequences with increasing TE. So these sequences are very fast and can be acquired during one single breath-hold acquisition. The most used relaxometry method was validated by John Wood using a multi-echo gradient echo sequence in a 1.5 Tesla equipment, and this is the linear relationship between liver iron concentration measurements and R2 star measurements. However, don't forget that relaxation rates are dependent on the magnetic field strength. So calibration curves obtained at 1.5 Tesla cannot be directly transposed to another field strength. We must double for 3 Tesla. So 3 Tesla and 1.5 Tesla have a linear relationship by a factor of 2. And another important issue in relaxometry methods is that the first echo should be as short as possible, and the echo spacing should be short enough to guarantee that the signal decay is captured. This is particularly relevant in cases of severe ion overload, because by the time of, if the first TE is too long, most of the MR signal will have irreversibly disappeared by the first image acquisition. Okay, so this is an example of a patient with hereditary hemochromatosis, and this is the liver biopsy with severe iron overload, and this is the MR sequence. And you can see on a multi-echo sequence the signal decay of the liver, but also of the pancreas, which is common in hereditary hemochromatosis. And this is the R2 star measurements and the correlation with the liver iron concentration measurements. Okay, the problem is that Different authors have derived different calibration curves for liver R2 measurements. I mean that all of them are extremely well correlated with liver biopsy. However, they reported different equations. And these differences result most probably from differences in acquisition methodologies, and also because we use liver biopsy as the reference standard. And we know that there is a spatial variability of iron deposits within the liver. Look at this example, how heterogeneous can be the distribution of iron in the liver parenchyma. And because the liver biopsy is not standardized and is highly variable across different centers, and those papers use different MR acquisition parameters, and also because these measurements can be influenced by the coexistence of steatosis, inflammation, or fibrosis. For example, if fat coexists in the liver parenchyma, the T2 star decay is no longer mono-exponential. So if relaxometry techniques model the T2 star decay as a mono-exponential decay rate, they will not account for these signal oscillations as water and fat signals become in and out of phase, and therefore the ability of MRI to measure R2 star accurately may be corrupted, particularly in cases of diffuse liver diseases when we have fat and iron in the liver parenchyma. So perhaps we can be more accurate in this scenario if we use the multi-echo chemical shift encoded sequences that I described for a fat quantification. So we can simultaneously calculate the R2 star and PDFF. And this is one example of a patient with chronic hepatitis, and we can see that he has severe steatosis and also iron accumulation that can be demonstrated both on MR using a multi-echo chemical shift encoded sequence. So in the last part of my presentation, I will present some cases from my clinical practice to demonstrate the use of quantification in different clinical scenarios. Starting with iron, we know that we have different scenarios of hepatic iron overload. And classically, we learned that the signal intensity of tissues could help us to differentiate these different scenarios. For example, we know that on hereditary hemochromatosis, we can have iron in the liver and also in the pancreas. But be careful, because in some cases, we can have liver cirrhosis with low signal intensity with iron in the liver and also in the pancreas in cases of non-hereditary hemochromatosis liver cirrhosis. This is rare, but can happen. Then in transfusional iron overload, usually we have iron in the reticuloendothelial system, so we will have a low signal intensity in the liver, but also in the spleen, the bone marrow, and we can also have in the pancreas. Whereas in the dysmetabolic iron overload and chronic liver disease scenario, we can have iron only in the liver, but we can also have iron in the reticuloendothelial system, in the liver and also in the spleen. So let's start with the first scenario, liver steatosis and iron overload in the scenario of dysmetabolic iron overload syndrome and chronic liver disease. This is a frequent scenario. A female patient with a moderate alcohol consumption. On ultrasound, we can see hyperechogenicity of the liver parenchyma, suggesting liver steatosis, and she also has hyperferritinemia. So the clinical question is hyperferritinemia due to primary iron overload disease, or it is related with chronic liver disease or steatosis? On the classical sequences, we can see a low signal intensity of the liver parenchyma suggesting iron deposition. But we know now that in the presence of iron, we cannot trust dual echo images to detect liver steatosis. So, of course, we need the multi-echo sequence, and we can see that this patient has iron overload, but also severe liver steatosis. So, most probably, iron deposition in this scenario is related with steatotic liver disease. And what about another scenario, very frequent, a patient that is referred due to hyperferritinemia? Well, those patients are suspected of having an iron overload disease. So in my institution, we use this algorithm. First of all, we must rule out alcohol, inflammation, and metabolic syndrome. And clinicians also look for transferrin saturation. If it is elevated, the patient undergoes the diagnostic workup for hereditary hemochromatosis. But if the transferrin saturation is normal or low, they request an MR to look for hepatic iron overload, but also steatosis. And we must also look for iron in other abdominal tissues, pancreas, bone marrow, spleen, because these measurements can help us to establish the differential diagnosis. We can lead the clinician to different scenarios. So in this patient, hereditary hemochromatosis was excluded, and he has also no history of blood transfusions, and he is referred for hyperferritinemia. And look that we can measure R2 star in the liver, that is quite elevated, but is elevated also in the spleen and bone marrow, not in the pancreas. And this suggests reticuloendothelial system overload pattern that we can see in ferroportin disease, that is a rare form of hereditary hemochromatosis, or in chronic liver diseases. And in these cases, well, a liver biopsy might be indicated, or more genetic tests to investigate this patient. And of course, another important scenario is hereditary hemochromatosis. Well, on hereditary hemochromatosis, the disease penetrance is low, and iron overload will progress only in few homozygotes. And of these patients, only some of them will develop morbidity associated with hemochromatosis. So to diagnose hereditary hemochromatosis, we need homozygosity for the gene mutation, so we need a genetic test, and increased body iron stores with or without clinical symptoms. So we need an evidence of iron overload. And because ferritin and transferrin saturation are non-specific biomarkers, MR quantification is very useful in this scenario. So nowadays, MR liver iron concentration measurements are being used to estimate the liver iron concentration in clinical practice and clinical trials, either for diagnosis iron overload or for treatment monitor. But don't forget that we must use validated acquisition and analysis protocols. Also, if we are monitoring patients, we must use the same relaxometry technique in different time points. This is an example of a patient with hereditary hemochromatosis by the time of diagnosis and after treatment. And we can see that the R2 star measurements now are normal. Another potential role of MR in hereditary hemochromatosis is to predict the duration of treatment. So these patients are treated first with intensive treatment with weekly phlebotomies to deplete the iron stores, and then with phlebotomies every 3 months to maintain the low ferritin values. In spite of being a well-accepted and safe procedure, phlebotomies may raise concerns regarding the limitations of daytime activities of the patient, so they decrease their quality of life. So by the time of diagnosis, patients want to know for how long they will need intensive treatment. So it would be very interesting to have a marker of total body iron stores, because the duration of treatment depends on the total body iron stores. And don't forget that liver iron concentration measurements are being used as a surrogate of the total body iron stores. So we thought to use MR measurements as a biomarker of total body iron stores to define patients who need treatment, and also to predict the duration of intensive treatment with phlebotomies. And in a small cohort of patients, we find that liver R2 measurements and pancreas R2 measurements were very good predictors of total body iron stores. And this is, of course, that these are preliminary results, but are very promising. These are 2 different patients, and you can see that using the MR measurements, the total body iron stores predicted are different, and of course these patients will need different durations of and different number of sessions for intensive phlebotomies. So this is a case of a patient that is now in maintenance treatment with phlebotomies every 3 months. And the serum ferritin starts to increase progressively over time. So the clinical question is hyperferritinemia due to iron reaccumulation? So an MR was requested, and we can see that, well, there is no significant iron overload, but this patient has liver steatosis. And this is very interesting because we know now that hepatic steatosis is more common than previously thought among patients with primary hemochromatosis and can be related with the disease progression. And we found in our cohort of patients that liver steatosis was a common finding in hereditary hemochromatosis patients under maintenance treatment, particularly in cases of ferritin higher than 160. So patients under maintenance treatment with persistent elevated ferritin levels could benefit from an MR examination to see if there is iron overload or if there is liver steatosis. Sorry, because this association of steatosis with a high ferritin values can be interpreted as steatosis itself, giving rise to an increased ferritin independently of iron overload, but it does not rule out the hypothesis that a minimal iron toxicity might also be involved in the pathogenesis of liver steatosis. And so to conclude, I want to tell you that I think that now we must get used to incorporate the imaging biomarkers of fat and iron in our radiological reports. And not only in the liver, but we can also measure these biomarkers in other abdominal tissues. And this could bring us new insights on iron overload diseases, or in cases of fat, for example, we can have some information about fat deposition in the pancreas or other abdominal organs. So to conclude, the classical MR sequences allow us to detect fat, but they should not be used for accurate quantification. MR spectroscopy is the gold standard, but is not widely available to quantify fat. MR imaging biomarkers of fat and iron are increasingly recognized as non-invasive biomarkers of fat and iron and now are considered an alternative to liver biopsy. So liver fat and iron quantification can be easily performed as part of any abdominal MR protocol because it takes only 1 or 2 breath-hold acquisition, and this can be done in 1.5 or 3 Tesla. Of course, the choice of MR imaging technique depends on the software availability and the local expertise at any given institution, but multi-echo chemical shift encoded sequences are widely available. R2-star measurements can also be performed in other abdominal tissues, which could help us in the differential diagnosis of iron overload diseases. But don't forget that with iron quantification, we must use the same relaxometry technique when we are following patients over time. And this is my presentation, and I thank you for your attention. Okay.
Thank you very much for this very interesting presentation. So I will invite all the audience to ask questions. So you can write your question in a Q&R box. So then I can read the question and answer it. So meanwhile, I have a question. You presented different methods. Some are more research, some are more clinical, and as you said, that sometimes the methods that we can use depend on the post-processing that we can do. So do you think that with time all these post-processing algorithms will be more and more incorporated directly in the vendor machines so that we can get the direct results?
Yes, well, these sequences, the multi-echo sequences, are already available in the different vendors. So we can do multi-echo sequences in everywhere. Then the post-processing can be done with tools from the vendors, or we can use in-house developed methods, or we can use some tools that are available on the internet from some firms that do these measurements easily. So we can upload the exam, and fat and iron quantification can be done easily. But we must be careful about iron. For fat, it's very easy, because PDFF is a fundamental property of tissue. So, and it is quite comparable across different vendors, different sequences. We can do PDFF easily. With R2-star measurements, the difficult part is to know how to convert the R2-star measurements in liver iron concentration measurements. And for that, we must be careful, because I show you how different methods lead to different equations. So, for example, an R2-star of 200. If I use one method, this corresponds to a liver iron concentration. But if I use another method, can correspond to a different iron concentration measurement. Of course, that these differences are not very important. But, well, if we are monitoring patients over time, we must be careful with that. So if we want to use the calibration formula from John Booth's paper, we should use that method for the acquisition of the multi-echo sequence. And this is the most tricky part of R2-star measurements and iron quantification. But of course that I think that with time, clinicians will start asking us to do more and more quantification, and we must report these biomarkers to get the clinicians used to this new language in radiology. And of course that some of these I'm not measuring iron and fat in every abdominal MRs, of course, but I'm doing the multi-echo sequence in every patient because this is one single breath hold. So I do the acquisition in the protocol because it's very fast, and then if I see any abnormality, or if the clinician asks me to provide some measurements, or if I'm reporting the abdominal MR and I'm seeing signs of liver disease, well, I can easily quantify the PDFF and R2 star.
Again, thank you. So there is a question from Angela from Valencia. So he asks if it would, if the automated liver segmentation would be useful, and what kind of methods, like artificial intelligence method, or if you prefer to draw ROIs and specifically segment.
Well, I think that liver segmentation with AI tools will be extremely helpful in this quantification, because it will give us, I think, more important information than ROIs. If we use ROIs, we must take several ROIs, because we see that fat and iron are very heterogeneous in the distribution. But if we have a tool with automatic segmentation, well, perfect. And of course, I prefer to look to the parametric maps, because I can see the distribution of fat and iron instead of doing ROIs. And the second part of the question, sorry?
Well, it was the global question. So automatic liver segmentation, is it useful? Artificial intelligence method. And actually, if you prefer sometimes to draw ROI on specific segments, for instance, where you suspect pathology, I imagine.
Yes, well, I use ROIs, for example, for quantifying fat or iron in the pancreas, because it is smaller, of course, than the liver, and well, it's easier to look at the multi-echo images to be sure that I'm measuring in the parenchyma. More easy. It's I think it's more difficult to do the segmentation of the pancreas, especially when we have atrophy. But for the liver, I think it is easier. Nowadays, I'm working with a tool from Key Liver, from KeyBeam, that do automatic segmentation, and well, it's easier, and I think that we get an idea of the whole distribution of these biomarkers.
Thank you. I have another question. So you told that you believe that it can sometimes replace the biopsy. So do your clinicians trust for now the results enough so that they could avoid to do the biopsy?
If we are talking about quantification of fat and iron, yes. We
Yes.
do not do liver biopsies now for this purpose. Of course, liver biopsies sometimes are needed, but for the evaluation of the disease, for a diagnosis, for example, to diagnose autoimmune hepatitis, or for another clinical question, not to quantify fat or iron. For example, in patients with hereditary hemochromatosis, we do not have now liver biopsies. In cases with NAFLD, with non-alcoholic fatty liver diseases, liver biopsy might be needed not to quantify fat, but to stage fibrosis, because fibrosis is the most important prognostic factor in these patients. And for now, we are not able yet to replace liver biopsies in some patients with NASH or fibrosis in this scenario.
But you believe that it can be done later with advance of techniques?
Yes, I think that particularly with MR elastography, we can measure fibrosis, and even with ultrasound, with shear wave elastography, we are getting more and more experience and confidence about measuring fibrosis with these imaging tools. And so if we can measure fat and we can accurately stage liver fibrosis, I think that we will not need liver biopsies in most of the patients with NAFLD.
Okay, thank you very much for your answers. Are there any other questions in the audience? I think not. Just thanks for excellent lecture. So I also want to thank you for this great lecture, and thank all the audience for being there and for the discussion. So I think that now we can finish the webinar, and it will be available later on the website.
Okay, thank you.
Thank you very much.